Hello, my name is Dr. Hadi Ramadan. I'm one of the providers at Boston IVF. Um, Thank you so much, anyone who joins. We'll get right to it. We're going to answer some questions. Any questions that you have, um, you can put in the chat, and I'll try to get to everything that we have so that we can address any concerns, and happy to take care of everyone's questions. Few questions that were submitted in the past few days. I can start off with that and then go on to the questions that are being put in the live stream. I can start with the first one. I'm 38. All testing has been normal. Wanting to do IVF. What is the best way to work on my egg quality as I'm waiting for my consultation? It's a very good question. We get that question a lot. There's not a lot of things that are that we could do for egg quality. But the minimal things that we could do is number one, prenatal vitamins. We could start on prenatal vitamins even if we're not actively pregnant. Prenatal vitamins are great to start with because they have a lot of vitamins that are important for the egg quality as well as daily life. The second thing that everyone should do is a healthy lifestyle. And I know that's not something that is extremely unknown, but a healthy lifestyle, no smoking, alcohol, not in excess, and exercising. That's the best things that you could do for your egg quality. So a good lifestyle or a healthy lifestyle, a balanced diet. There's no a secret or magic diet. It's a healthy diet, a healthy lifestyle, exercising, and prenatal vitamins can help a lot with the egg quality. Another question that was given to us before is, can you touch on egg freezing and embryo freezing, which will yield a higher percentage of viable options? And that's a very good question. So with egg freezing and embryo freezing, and we're talking here about fertility preservation, or at least what they call banking eggs or embryos. Definitely, when patients have a chance to freeze eggs, they should definitely do that. The advantage of freezing embryos is, to be honest, information. When we have, let's say, we freeze a certain number of eggs, unfortunately, it's hard to know which ones will fertilize and which ones will become normal embryos. When we freeze embryos, we are able to get that information, and then we could counsel the patient after that cycle. We got enough number of embryos, for example, to say, okay, we're good for now. We can try to transfer the embryos at a later date when the patient is comfortable with it, or that we don't have enough embryos and we might need another cycle. So freezing embryos might have that advantage. Now, when we freeze eggs, of course, it's a very advantageous thing, and it's a great insurance policy for a lot of patients who could do that. Once we thaw them, there's a 92% chance of survival. So it's a high survival rate. But again, that's why embryo freezing might have more advantages if there is a chance to freeze embryos. But if there's no partner or donor sperm involved, and freezing eggs is what's available, or that's what the patient is able to do, then definitely go ahead because it's a great option as well. One question that was also given is, how many times do you generally advise doing IUIs before moving to IVF? And again, this depends on patients, but I could talk in general when it comes to IUIs. Of course, there are different diagnoses that need IUIs. Some diagnoses need IVF, moving to IVF immediately. But let's talk about unexplained infertility, which is when we do the workup and we don't know why in specific, and that's 30% of the time. We don't know why specifically the patient is not getting pregnant. So we try to do IUIs, which is intrauterine insemination, which is basically a shortcut between the egg and the sperm. And we try to, using a catheter, put the sperm inside the uterus, which what we call intrauterine insemination. There is a big study that was done here at Boston IVF, actually, several years ago, and it showed within that diagnosis, usually we recommend 3 IUIs before moving to IVF. Anything beyond 3 IUIs might not be, the cost benefit is not good. So it's best to do 3 IUIs, and then it would be the best decision is to move to IVF if after 3 IUIs we haven't been able to get pregnant. Keep in mind the caveat is that there's a lot of insurances that require 3 IUIs or even 6 IUIs before moving to IVF. But in general, the studies have shown 3 IUIs before moving to IVF with unexplained infertility diagnosis. One question that also was asked is what happens after the first appointment? What is the timeline to start? Do I have to be at a specific day in my cycle to start? Very good question. And I know a lot of patients when they start with us, they're very eager to start, and we are eager to help as well. But there's a lot of things that happen. Usually, the first appointment is getting to know the patient. What happens is that someone like me or one of the other providers at Boston IVF would meet with the patient, get a history. What is the goal? What is the goal for their family size? And then their gynecological history, as well as the history of the partner and what the general goals are. After that, if we're talking about a infertility workup, we need to do the workup after that. And usually what I say at the end of the first consultation is that we don't have enough information to know what the treatment should be. Is it IUI? Is it IVF? Is it a surgery? Is it something else? Is it a certain medication that we need to give? Because we don't know that, we need to do a workup. And usually I tell the patients, expect a call from our nurses in the next few days. Then they would get a call, and then the nurses would give them instructions on how to do the workup. The workup itself requires blood work from both partners, as well as imaging. Some of that blood work and the imaging relies on the menstrual period. So that's why it might take some time to do all of that workup, because some of the workup has to be done on days 3, 4, or 5 of the menstrual period. And the imaging has to be done also during that time. So that's why it might take some time to do all of that workup. Once all of that is done, we do a follow-up visit, and then we address anything that came up, and then we put in a treatment plan. And then the rest of that question is, do I have to be at a specific day in my cycle to start? Again, we have to do the workup, then follow-up visit again. And then after that, we would put in a treatment plan, which might have to start on the day of the period. But this all depends on the patient. It depends on the workup, and it depends if there's anything to treat. One thing I always tell patients, which all of us here, are asked this question a lot, is can we start as soon as possible? Unfortunately, the things that are obstacles are, for example, insurance prior authorizations or anything that has to be done outside of the medical part of it. Usually that's what takes time. But then after that, as soon as everything is done, we're happy to start the treatment and go ahead and do it. And again, another question was, how long after my consultation will my first IVF cycle be? Again, it depends on, so the first consultation, then we do the workup, then we follow up, and then at the follow-up, we put in a treatment plan. And a lot of times there's the insurance prior authorizations and things like that that take time. But then after that, we start with the treatment. And I can never promise a timeline. All I can promise is everyone on the team will be actively working on doing this as soon as possible. One question was, which protocol is more recommended for better successful rate for frozen embryo transfer? Natural, modified, or fully medicated? Which protocol is more beneficial for what type of patients? Very good question. So Let me explain all of these for patients who don't know on this call. So for frozen embryo transfer, so basically we have embryos that are frozen and we're trying to transfer them. The cycle, well, when we call cycle, this means that someone starts with their menstrual period, and during that cycle, we're going to transfer the embryo. It could be natural, which means that we are monitoring the patient with blood work and ultrasound and see where they are in their cycle so that we can transfer the embryo at a time where if let's say they're doing this the natural way, the embryo would implant during that time. So we try to mimic a natural cycle by transferring the embryo at a time where the uterus is receptive. That's a natural cycle. A modified natural cycle is when we give medications in order to help patients ovulate and help them have a follicle that will release the estrogen in the body and will help the endometrium or the uterus lining thicken so that it's more receptive to the embryo. So basically, it's like a natural, but we're giving that boost of medications in order for them to ovulate and help transfer the embryo. Fully medicated is that when we take over the cycle or we take control of the cycle. And that's when we, instead of waiting for a follicle to grow or and release the estrogen, what we do is we give the estrogen ourselves. And the patients would take oral medications like estrogen in the beginning of the cycle. And then at one point, we do an ultrasound, usually after 14 to 18 days from the beginning of the cycle. We do an ultrasound. We see if the uterine lining is thick enough. And once we say, okay, we're ready, around 6 days later, we transfer the embryo and we start also with progesterone during that time. So basically, instead of relying on the follicle or the ovaries to release those hormones, we give estrogen and progesterone. A question that was asked as well, which protocol is more beneficial for what type of patients? And there's a lot of research ongoing right now. Natural and modified are gaining traction. A lot of patients are getting pregnant with natural and modified cycles. The fully medicated cycles also have been very beneficial. Someone who is ovulatory, for example, and able to ovulate on their own and don't have any problem with their lining thickening on their own might be good candidates for natural cycles. Patients who might have anovulation, for example, or not ovulating on their own might benefit from medication such as in the modified natural cycle. And some patients have a tough time to thicken their endometrium, so we have to give them estrogen and progesterone. So it's hard to say which patients lie in which category. Sometimes we do a natural cycle, and unfortunately, there's no pregnancy. We switch to a medicated cycle to see maybe that works. It's hard to say which patients lie in which category, but we do know that with patients who are able to ovulate, we might be able to give a natural cycle or a modified natural cycle. And patients who are, it's a bit difficult to thicken the lining, such as patients who are older, for example, and need a boost when it comes to the estrogen, a fully medicated transfer cycle might be very beneficial. One question was, how many embryos do you recommend banking per desired child? I could answer that question when it comes to if we have enough genetically normal embryos. So when we have genetically normal embryos, with each genetically normal embryo, there's a 55 to 65% chance of having a child. So usually if we want to say, okay, banking enough embryos to say we have a good chance of having one child, I would say at least 3 genetically normal embryos. Banking 3 genetically normal embryos might help, or at least be okay for us to say we're okay with having one child from there. One question was, what protocol do you prefer for diminished ovarian reserve? Also a very good question. There's multiple schools of thought when it comes to diminished ovarian reserve. Diminished ovarian reserve means when someone has a low number of follicles or a low AMH, or a previous IVF cycle that the patient did not respond to the medications adequately. There's multiple protocols that we can think about. It really depends on the patient. I always tell patients the best teacher, unfortunately, is not the labs or the antral follicle count or the AMH level to give the best protocol. A previous IVF cycle is unfortunately the best teacher. And a lot of times patients go through an IVF cycle. We learn a lot about how they respond and how they responded to that protocol in specific. And if they fail certain parts of that protocol, we know that in the next protocol, we could do better by changing certain things. With diminished ovarian reserve, there's a couple of schools of thought. Some doctors like to be a bit more aggressive so that we can stimulate each and every follicle that we're seeing on the ovary. And some doctors are in the schools of thought that we do a mini stim, which means that we give a low number of medications because we have a low number of follicles. Both have been proven to be very efficacious and beneficial, but there is no specific protocol for diminished ovarian reserve, and it really depends on the patient and how they responded to previous protocols, and that's how we try to cater the protocol towards them. So sorry, I don't have an answer to which one I prefer. It's usually patient specific. Um, One question was, I have a frozen embryo with Boston IVF. Can I do an embryo transfer while breastfeeding my two-year-old daughter? A lot of us have different ways of dealing with breastfeeding. We try our best to counsel patients to wean off breastfeeding for a couple of months before transferring an embryo, because the hormonal profile of someone who's breastfeeding might not be the best for a receptive endometrium. So this would have to be weaned off for a couple of months before we try a transfer cycle. Different doctors approach this differently, but that's how I approach it. I see here, do you repeat the workup if you've had a workup already? Blood work, semen analysis, HSG, found nothing and have had 4 pregnancy losses with no success. Insurance covers everything. Do we just start? Very good question. And whoever posted that question, I'm very sorry about what you went through with the pregnancy losses. But what we do in this case is that we always, before a consultation, we always get the records, or at least if the records were sent to us, we look through them. And if those records or that workup is up to date, and we see that there's no reason to torture the patient and have them go through that again, we look at the workup, we make sure that everything that we need is there. And if that's the case, we just try to put a treatment plan in. And again, a lot of times, unfortunately, this workup might be done by other providers or other clinics that might not cater the workup towards recurrent pregnancy loss, as we call it. So there might be an additional testing that needs to be done, but we try our best not to put the patient through testing twice and try to get them as soon as possible into treatment if we have all the information. I have a question here. I had an egg retrieval and the results were as follows. And a lot of patients might relate to this. 32 eggs retrieved, 24 mature, 14 fertilized, and 3 embryos. And I would like to know if it is normal for the retrieval to yield such a high number of eggs, but result with so few embryos. Um, Again, it's very patient dependent. We see a range of results when it comes to embryos. 32 eggs retrieved, 24 mature, 14 fertilized. So we have a good number of eggs. We have a good number of mature eggs, 14 fertilized with 3 embryos. I mean, 3 embryos is a great number, especially if this is a younger patient. So we're less concerned about abnormal embryos. Um, when these things happen, and these things happen often where we have a big number of eggs, but then there's a low number of embryos. Usually, what the provider, and I'll tell you what providers usually do, they go through the progression of getting the eggs, how many fertilized, and how many were go to day 5, 6, and sometimes 7. And depending on where the problem was, they might address it differently with patients. So in this case, for example, this patient might go to the provider, and the provider would analyze where we might have done better, and they would counsel on that. Sometimes it's a sperm issue where the progression from fertilization to embryo might be with the quality of the sperm. Sometimes it's the quality of the egg, sometimes also the quality of the sperm, and that might be something that might be addressed. But it's hard to say. It's really hard to say that this is exactly the problem, but there are things that we could do in order to increase the number of embryos in the future. I see here a very important question. Could you explain PGT-A testing? If we prefer to do this test, should we do it each cycle? And I can't tell you how many conferences I've been to where PGT-A testing is debated. And we study this a lot and we counsel about this differently, but I'll give you a general overview about it. PGT-A testing, first they asked to explain it. PGT means pre-implantation genetic testing. So pre-implantation, before implantation, genetic testing. And then the A means aneuploidy, which means that aneuploidy is the number of chromosomes is not 46 as we have them. So it could be an extra chromosome or one less chromosome or a part of a chromosome is gone. And that's what we call aneuploidy, because euploidy is when we have the right amount of chromosomes. And that's what we test for, because with patients who are above the age of 35, we see more and more genetic abnormalities in the egg because of extra or less chromosomes, which is why we would want to test the embryo to see which ones are genetically normal. Now, do we prefer to do this test or not? Again, it depends on the patient. In younger patients, we have less number of embryos that are abnormal. And PGT-A testing might be something that the patient wants, but with younger patients, usually we have a good number of untested embryos that would be normal. However, this becomes a bit different when we're talking about patients who are 35 and older. A lot of patients want to make sure that what we're transferring is a normal embryo or a euploid embryo. And a euploid embryo, the difference between a euploid embryo or genetically normal embryo and an untested embryo is that the genetically tested embryo and the normal embryo has a 55 to 65% chance of success. The untested embryo, it depends on the patient age and criteria. So, and it's usually less than 55 to 65% chance. We have patients who have been through multiple losses and want to try to avoid having another loss. Unfortunately, PGT-A testing can increase the chance of success, but it's not a 0% chance of having a miscarriage or no implantation. There is a 35% chance that we might have either a miscarriage or no implantation. So it's a good test to genetically test the embryos, but it depends on the patient goals, and as long as they understand why we're doing it and what it gives us as an advantage, yes, I do prefer to do it, especially older patients. What is your criteria for transferring multiple embryos? There's actually, it's not my criteria. There's ASRM, the American Society for Reproductive Medicine. We have a table that gives us criteria on how to transfer multiple embryos. In the past, they used to transfer multiple embryos in order to increase success, and we've had a lot of twins and triplets from IVF, and that was in the past. But in the past few years, the guideline came out to try to minimize the number of embryos transferred, and that's to decrease the number of twins and triplets, because at the end of the day, being pregnant with twins and triplets is a high-risk pregnancy and might end up with either unfortunate miscarriages or second trimester losses or preterm delivery, which might be detrimental to the newborn and to the parents. So we try as much as we can to transfer less embryos. Keeping that in mind, when we have a genetically normal embryo, which we just talked about, usually we transfer that one. When we have untested embryos, there is that table from the American Society for Reproductive Medicine. And there's a table that says, for example, if the patient is at a certain age, let's say 38 or 39 or 40, and they've had a previous IVF cycle that didn't work, then they hit criteria, or they hit the criteria to transfer 2 or 3 embryos. If they are 42 years old, we could transfer maybe 3 or 4 embryos that are untested. If it's a day 3 embryo, we can transfer 4 embryos. If it's a day 5 embryo, we can transfer 3 embryos. So there's certain criteria that our excellent embryologists also look at, and the providers, and that's how we usually decide on how many to transfer, multiple embryos. And we've always had patients who transfer multiple embryos. They just would be patients who hit that criteria, so that we can increase the chances of getting pregnant without really increasing the chances of too many multiples. Someone asked, if I transferred on November 21 and my positive result was December 2, what is my gestational age today? A very good question. I can't do math at the top of my head. I usually use, there are apps that we could put in dates of the IVF transfer. There's an app called the Ferring app, Ferring, Ferring. And it's kind of like a calendar where you put in your date of transfer and what you transferred, and they would give you your gestational age. What features are most necessary to make an embryo transfer most effective for the IVF procedure? Of course, if we're not talking about the embryo itself, we talked about the genetics of the embryo and all of that. But if we want to talk about the the uterus, usually what's necessary is a thick lining, usually above 6 to 7 millimeters. And it depends whether it was a natural, modified natural, or a medicated cycle. Based on that is when we transfer the embryo. So there's a calendar in each embryo transfer cycle, and we try as much as we can to hit that receptive window in order to transfer the embryo. And that's something that your clinic and your provider would be watching and going through in order to have a successful IVF procedure. And of course, the quality of the embryo. And usually those are the criteria that we look at for an IVF transfer procedure. At what point do you recommend donor eggs for a 39-year-old? First, let's define donor eggs. So donor eggs is when we get eggs from patients who have donated their eggs, usually from an egg bank. They are usually younger patients with good quality eggs that some patients use with, for example, their partner's sperm in order to get pregnant. Usually, we get to donor eggs at a point where the patient herself is not able to use her own eggs, or at least the IVF procedures have not been successful of getting her own eggs. And the question was, at what point do you recommend donor eggs for a 39-year-old? There's no specific criteria to say at 39 years old, this is where you get to donor eggs. The donor egg conversation comes up after we've exhausted several paths when it comes to IVF. Sometimes we are able to get pregnant with patients' own eggs at 42 years old. Sometimes we need donor eggs at the age of 35 years old. It depends on the patient. Some patients who have been through, for example, premature ovarian insufficiency need donor eggs, and that's at the age of 35, and sometimes some patients need that as part of the treatment. So there's no age related to when to give the donor egg. It depends on the patient. It depends on what solutions have been exhausted, where are we in the treatment, and if the patient is amenable for donor eggs. And usually that's a conversation that happens extensively with the provider after IVF cycles. And if that solution did not work, then donor eggs are suggested. Just to confirm, should the PGT-A testing be done every cycle, or can the embryos be reserved from multiple cycles and tested at once? Very good question. Usually, if PGT-A is the decision, again, I said, you could do PGT-A, or you could do untested embryos. But if your decision was to do PGT-A, which is again pre-implantation genetic testing for aneuploidy, usually we do it on the spot, which means that you would go through the IVF cycle, which is around 2 weeks. We get the eggs, we inseminate them with the sperm, and then 7 days later, the lab would tell, or at least the clinic would tell you which eggs fertilized and became embryos, and how many embryos we got, and how many embryos were biopsied and frozen. That biopsy is sent out to be tested, and then several weeks later, you are told which ones were normal, which ones are not. Now, should the PGT-A testing be done every cycle? It has to be done on the spot, because if the alternate scenario would be getting the embryos, freezing them, doing multiple cycles, and then testing them all, that means that the ones that were frozen in previous cycles have to be thawed or warmed, biopsied, then frozen again. This warming and then refreezing might be injurious or might hurt the embryo. So we don't recommend that. We recommend that, as soon as the egg fertilizes and becomes an embryo, we have the embryo right there, we biopsy it, and then we freeze it and decide on transferring it later on. So we do it on the spot. So we don't recommend retesting later. We recommend testing it on the spot, and the results themselves take a few weeks. And it is important to do it on the spot because we do want to know whether we need to do more cycles or not. Does the patient have a say in what type of frozen embryo transfer? Trigger shot, natural, or medicated? Very important question. I mean, at the end of the day, this is a conversation with the patient. Our job as providers is to inform you, give you our best experience, what the research has shown, and what we think would be recommended. Always bring up your concerns and always bring up what you have looked up in the literature or online. Of course, all our patients are looking things up online and making sure that they're doing the right things. Bring up your concerns. Let your provider explain to you the differences and what is a myth and what is true and what they think is best. And a lot of times the patient might bring up something and say, hey, how about this? And if the doctor doesn't have strong feelings or strong contraindication against it, it might be something that we do, because a lot in our field is still being researched. A lot of things that we do might help. We don't know whether they might help or not, and we might add them. Research in the future might prove that it's helpful or prove that it doesn't work. And there's a lot of things out there. So let your provider explain to you what has been researched, what the research shows, and what can be recommended. And most of us are happy to, all of us are happy to have a conversation. And if the patient wants something different than what the doctor is recommending, we're happy to have that conversation and say why and why not, and to reach a compromise. Just looking at if we have more questions. When do you know you need to conduct immune disorders or blood clotting disorder disease after failed transfer of a normal embryo? It's again, the normal embryo has a 55 to 65% chance of having success. A lot of patients, unfortunately, are very disappointed that they went through the IVF cycle, got embryos, got the result of a normal embryo. They're very excited about that transfer. Unfortunately, a lot of times, well, 35% of the time, 35 to 45% of the time, it's unsuccessful. And it doesn't mean that there is a disorder or an immune disorder that is happening. A lot of providers usually wait after 2 transfers or 3 transfers of a normal embryo to say, okay, we could do additional testing to see if there's anything that is happening. But my recommendation is that to keep those statistics in mind is that the failed transfer of a normal embryo doesn't mean that there's something that needs to be treated or something that was missed. Unfortunately, a lot of these things are not 100%. And so we try this again, see if that works. And if it doesn't, we try to do some workup and maybe change the transfer protocol in order to achieve success. Do you recommend back-to-back cycles for women with a diminished ovarian reserve? Again, diminished ovarian reserve is when we have a low number of antral follicles and a low number of AMH. Um, do we recommend back-to-back cycles? The problem is with diminished ovarian reserve, that usually happens at a later stage or older age, and time is usually not on our side. So yes, if it's feasible, I know it can be very difficult for the patient to undergo injections um, and go through an IVF cycle and an egg retrieval and then go through another one. It's heavy on the patient, and we do understand when sometimes patients need a break. But yes, in order to answer that question, time is not always on our side, so we do recommend trying our best to get as many cycles as possible. But it is very understandable when some patients need a break before going on to the next cycle. Typically, what is the time frame from consultation to first transfer, assuming there are normal embryos yielded? Um, Again, the consultation happens, and this is the timeline, and this is the most frustrating part of patients' treatment is the time. And we start with the first consultation, getting to know the patient. We order the workup. That takes about a month and a half, up to 2 months, and then we do a follow-up visit. At the follow-up visit, if IVF is the best to do, then we put in a treatment plan, and then for us, we're happy to take care of you immediately, but unfortunately, there's a lot of times where there's insurance prior authorizations and a lot of paperwork that needs to be done that we have no control over, and we're just waiting for the approval. Once it's approved, we can start with continuing the treatment. Once we get the okay, and usually sometimes that takes several weeks from the time that we follow up. Once we put that in, a lot of times we wait for the menstrual period and then we start the treatment. The treatment itself differs from patient to patient, but an overall view, a lot of times what we do is a couple of weeks of birth control pills, for example, to quiet down everything, and then a couple of weeks of injections until we get to the egg retrieval. Once we get to the egg retrieval itself, if we're talking about because they asked here normal embryos, if we're talking about a IVF cycle where we're testing the embryos, what we would do is we would retrieve the eggs at the end of those 2 weeks, retrieve the eggs, fertilize them. 7 days later, we would freeze them. Several weeks later, we would find out how many of those were normal, and that's when we follow up to decide about a transfer. So all of this takes several months, and a lot of things can make things fast and can make things slow, but it takes several months until we get to that first transfer if we're talking about normal embryo. So my advice is, if you're thinking about it or this is something that you want to do in the future, get a consultation as fast as possible. You could try to start with a workup, start with having that conversation. Even if you have things that you're still trying to think through, talk about them to your provider, and so that we can start with the process. Is it ever possible to do IVF with high FSH? So FSH is a follicle stimulating hormone. Usually this hormone, if they're asking about high FSH can sometimes happen when patients are perimenopausal, for example, and that's when high FSH happens. And that's if we are getting an accurate FSH on day 3 of the cycle, and it's very high. That means that we have a low ovarian reserve, and we might be at perimenopause. Is IVF possible? It might happen. It has low success. A lot of times, it's very difficult to get pregnant with high FSH and with your own eggs. It's more possible with donor eggs because high FSH shows that we have a low ovarian reserve and we might need to resort to donor eggs. So in that specific situation, a donor egg scenario might work with IVF, but high FSH might be difficult to overcome with patients' own eggs. I have a question that says, had polyp removed, put on Clomid, got pregnant, and that was a chemical pregnancy right before IVF start. Could that indicate a good response to IVF? Um, it's hard to say. I don't think that this is a bad sign. It's actually a good sign. It's a good sign that you ovulated on Clomid, and you did get pregnant. Most likely, yes, you will have a good response to IVF. Um, but again, what is a good response to IVF? Is it responding to the injections? Yes, most likely you will respond to the injections because it seems like you are ovulating and you did respond to Clomid, so that is a good sign. But also, we want to look at the quality of the eggs, fertilization of the eggs, and how many embryos we get, and then hopefully that would be our success. Um, What is the recommended time to abstain from sexual activities until sperm is collected for egg insemination? Usually, we recommend abstaining from sexual intercourse 2 days before egg insemination, not more than 10 days. So between 2 to 10 days is what we recommend. At 29, is it a concern to have 1.22 of AMH and 11.5 of FSH? Again, we need a big picture. We need, there's a lot of workup that needs to be done. AMH above 1 is usually a good sign. And again, AMH, it's a hormone that gives us kind of idea how you respond to IVF medications. Doesn't mean that you won't be able to get pregnant in the future. Doesn't mean that you're not able to get pregnant right now. The 11.5 of FSH, again, this needs to be put into context with the rest of the labs because it might be slightly higher where you are advanced in your cycle. And we need to look at the estrogen and the LH and the progesterone at the same time. So a lot of these things need to be looked at by a provider like us at Boston IVF. They could give you better counseling instead of just relying on the number and looking it up. It's best to give those numbers to a provider who can counsel you better. I'm looking at the questions. I think we're almost done. I want to thank everyone for putting in their questions. It's really important to ask as many questions as possible. I know a lot of patients look these things up online, and unfortunately, you'll find a spectrum of things online that might be accurate and might not be very accurate. So, compile your questions, ask them to your provider. Your provider is the best resource to answer these questions. And it's a very frustrating path, and it's a very frustrating treatment time. So we do understand that this is something that makes a lot of patients frustrated and anxious about results and trying to get pregnant and getting that precious baby. But we're here for you. We're here to answer your questions. We're here to treat you, and hopefully we can get you the family size that you're hoping for. And thank you very much. Happy holidays for everyone. And please log into our future Q&A sessions. Thank you.